frontier. I invite all the speakers onto the dais. We'll be having 6 talks on the OCT part of it. To start with, I invite Dr. Pushpanjali, who will be speaking on the mechanism and evolution. She's a senior consultant and VR surgeon practicing at Isha Netralaya. Dr.
Good morning, friends. We have been lucky enough to witness various new technologies in the field of ophthalmology. These innovations are not only new, but also amazing. Yes, my friends, it's an exciting time to be an ophthalmologist today, and I want to share my excitement with all of you. These emerging concepts are like the dawn of a new era in retina medicine. There's no comparison between what we can do today and what Hermann von Helmholtz achieved with his first ophthalmoscope more than 125 years ago. Yes, new modalities allow us to visualize retinal anatomy in incredible details we simply can't appreciate with direct visual examination. The most revolutionary of these techniques being the OCT or optical coherence tomography. It's difficult to overstate the importance of OCT in helping physicians diagnose and track ocular pathology. It's a 3D imaging akin to getting a cut slice of the retina without the use of knife. The OCT can acquire an optical biopsy of the retinal layers, and we can visualize each and every minute retinal detail. OCT jumped into our lives in 1991 when Huang Jie and his colleagues published about a non-invasive cross-sectional imaging in biological systems. Since then, major advancements have been made. Time domain of OCT gives you a very pixelated image, whereas you get a clear image with higher resolution with spectral domain and a wider image with self-source OCT. But this is an era of multimodal imaging, so only anatomical details are not enough, and we require an angiogram for visualizing the vasculature of the retina and to come to a certain diagnosis. Although FFA and ICG, that is indocyanine green angiography and fluorescein angiography are available, which give us wide field images of dynamic blood flow information, but these tests are invasive and cause various side effects ranging from minor allergic reactions to even death. These tests are slow and can't be repeated again in the same setting and give only 2D imaging of the superficial retina. So we need an imaging which gives us the best of both worlds, that is, the depth of the OCT and the visualization of the vasculature without the use of dye, which can be done with fluorescein angiogram or ICG. So welcome to the world of optical coherence tomography, angiography, or no dye angiography. OCT angiography runs on a simple principle that in a static eye, the only sole moving structure is blood flowing through the retinal vessels. That is, erythrocyte movement is the contrast medium. And the basis of the technique is to perform repeated scans in the same area and extract changes in the resultant images. With OCT angiography, we are able to separately visualize the vessels of the superficial retina, deep retinal layer, choriocapillaries, and the choroid. The color retina depth map combines superficial, deep, and avascular retina maps and provide depth visualization of the retinal and choroidal blood flow. The uses of this imaging is to visualize the vasculature of the central macula, and it can be used in diseases like age-related macular degeneration, diabetic macular edema, retinal vein occlusions, IGT, we can visualize the microvasculature in optic nerve diseases. Also, certain aspects of other diseases like polypoidal choroidal vasculopathy, posterior acute middle maculopathy, central serous retinopathy, and sickle cell retinopathy. There are various OCT angiography systems available, like Zeiss Angioplex, Optovue AngioView, Topcon, SSOCT, Heidelberg Spectralis OCT, and Nidec AngioScan, and Canon AngioExpert. Various algorithms are used, and in a recent study, it was found that OCT-based or optical microangiography, that is OMAC, as the method utilizing complex OCT signals to contrast retinal blood flow, provided the best visual result. Other algorithms are spectrum amplitude decorrelation angiography, OCT angiography ratio analysis, speckle variance, phase variance, and correlation mapping. Various devices have come into the market by different manufacturers. Though it seems to be a self-evident truth, but OCT angiography is not a replacement of fluorescein angiography. OCT angiography is likely to transform our understanding of retina in ways not possible or even foreseen with fluorescein angiography. OCT angiography is a safe, fast technique, and it provides a great deal of interesting information, and it can be readily incorporated in our clinical practice. Hence, OCT angiography has a very bright future. Thank you all for your patient listening.
As we delve more into the details of the recent advances in OCT, Dr. Praveen comes up with the next topic. He works as a consultant with the Eye Foundation, Bangalore.
Good morning, everyone. As already mentioned, that OCTA is one of the most promising functional extension of OCT. Despite its recent introduction, the potential impact can already be felt. The field is really expanding. Basically, what is OCT angiography? By definition, it's isolation and extraction of the microvascular circulature from the OCT image data by using specialized image acquisition and processing technique. Today, mainly I'll be focusing on both the image acquisition, the processing technique, which will help in how to read the OCT angiography. It is basically a functional extension of OCT, which visualizes the microvasculature by detecting the motion contrast from the flowing blood. The basis is basically to do repeated scan at a single point and then to examine the resultant image for the changes. Stationary structure, as we all know, it will show very little changes, whereas moving structure, in case of OCT angiography, the blood through the vessel can show changes from one image to the next image. So what is done is a raster scan pattern is taken where multiple B scans are taken from the same point, and this generates a volumetric data which is then processed to give an OCT image. As described by Dr. Sada, there are three flavors or three major things which involves in OCT angiography. They are basically either the phase or the magnitude, or a mixture of both, which is called as a complex thing. In phase Doppler-based OCT, the processing method involved is the phase, and the control used is a Doppler shift. Commercially, availability of this machine is doubtful. In case of magnitude-based OCT, what we use is the variance of the OCT magnitude signal, and the control used is decorrelation. And in complex-based, we use a processing unit of both Doppler shift as well as the decorrelation. The commercially availability are the Zeiss as well as the SS-based OCT. Now, what is this phase-based OCT? They consist of either a contrast, a variance, a subtraction, or a Doppler-based angiography. Moving structure are the one which produces the phase shift. The phase information was always there. They are complex data which was there in the older OCT machine also. But these data were generally discarded, basically because they occupy a lot of the data. So they were discarded. And recently this was looked into with newer modalities and all. And by eliminating the Brownian motion and the fixation artifact, what is left is the residual motion in the eye, that is the blood flow. In the variance, the major pitfall was the motion artifact, which required high quality imaging in some patients. Thus came into fixation tracking, which was a key requirement in the phase variance, which adds on to the cost of the machine. In magnitude base, we have the correlation mapping, the speckle variation, and the split spectrum. In split spectrum, what is we use is decorrelation, which refers to the fluctuating value of the OCT intensity. We all know that whenever a blood flow, the fluctuation in the amplitude of the OCT fringes happens because RBC enters and exits a particular voxel, and a greater fluctuation means a greater flow. Previously, a full spectrum was used, but splitting the spectrum yields a better signal-to-noise ratio, giving a better clarity of the images. In complex-based OCT, we have basically two, the OCT microangiography as well as Egan's decomposition. This all terminology will be used till we have a stable and good commercial system available. OMAG was basically coined by Ricky Wang. He combines the element of both phase-based as well as magnitude to detect changes in the scatter signal through moving structure. The advantage of OMAG is mainly it gives a good depth-resolved images. Till now, what we have to see the retinal vasculature is basically a slit lamp and indirect ophthalmoscopy. Other than that, we have the fluorescein angiography, which gives a better thing for the retinal vasculature, as well as ICG, which gives a good thing for the choroidal vasculature. The major pitfall are they require intravenous injection, which is time-consuming and known for adverse effect. In addition, the dye leak and stain blur the boundaries of the capillary dropout and neovascularization. Finally, these technique provides only little depth imaging due to the two-dimensional nature of the acquired images. Coming to the anatomy, we all know that retinal capillary plexus consists of three major networks: the radial peripapillary network, the superficial retina, and the deep retina. What we all see is the superficial capillary plexus. The radial is not seen basically because of the alignment, and deep not seen possibly because of light scattering of the retina. Since FA cannot dissociate between this layer, the second layer or the deeper layer ceased to exist because most authors ceased stressing on the existence since 1960. Thus, lot of study was done for this examination. So we have basically two plexus, the superficial plexus, which are basically transverse with interconnecting plexus between the arterioles and the vein. And deep plexus are basically polygonal unit with capillaries which converge towards the epicenter called the capillary vortex. Now, how do we construct the slab? The present en-face image of the superficial plexus was obtained with a slab between the inner boundary of the ILM and the outer boundary at the inner plexiform layer. And the deep plexiform was beneath that till the inner plexiform layer. The two capillary plexus, as seen on the OCT-A angiography, were on the left-hand side. What you can see is the superficial plexus, which forms interconnected plexus between the arterioles and the venules, and on the right-hand side you can see the deep plexus. Now, what you see on the top figure is a FA picture. We see single vessels with haze in between. This haze was considered as a haze from the choroid, which now recently can be attributed to the deep plexus also. Coming to a little bit on the artifact of imaging. In any imaging system, there is an object which has to be imaged and an image which is created. Unfortunately, in every real-world imaging methods, the image is not perfect. There is always an extra or missing piece. This condition leads to a defect called image artifact. Thus, all the imaging pictures what we get will have a fact as well as a defect. So almost every imaging artifact produced by imaging system can be explained, but to do so you should know the proper understanding of imaging strategies which is required. If you see this image, we see a FSH which is distorted. So whenever we see an imaging, it should not be assessed by a single picture. We should have a correlating fact with the fundus picture or other imaging. Now, when you see the fundus picture, you have some vitreous opacity above the picture, which is showing a shadowing on the B-scan image of OCT on the left-hand side. So this is basically what we call as projection artifact. Projection artifact can be caused by light passing through a blood vessel. So when a light passes through a blood vessel, it can be either reflected, refracted, or absorbed. The reflected image are the one which gives us the OCT images. However, the light that has passed through a moving blood also encounters tissues below it. For example, when a light passes through the blood vessel, the last thing it encounters is the RP. When it reflects, you can get you can have a projection artifact in the form of a vessel. Thus, projection also occurs from superficial retinal vessels, which are seen in deeper retina, or the retinochoroidal vessel, which can be seen on the sclera. They are nearly always present in any structure that is located below the vasculature. Just showing a superficial picture, when you see a deep picture, you can see this image. This is a projection defect of the vessel seen here, and the same thing on the choroidal thing, you can see a hypoflow area, which is also a projection defect. Depending on how you segment also, you can get this projection artifact. Like if you see the segmentation here is taken just below this drusen. So when you see the choriocapillary layer, you see a hypostructure, which is basically a projection artifact of this drusen. When you take the same picture and segment above the drusen, what you see is a hyperflow. So we can confuse this with a neovascularization. So this is basically a projection defect from the retinal vessel at that level. The second common thing what we see are motion artifacts. Motion artifacts are caused due to multiple things like cardiac cycle, breathing, tremors, and microsaccades. This is basically to show a pictorial image where multiple images are taken and you get a good vessel diagram on the right-hand side. A particular motion at particular time will cause a defect which can appear like this, which is adjusted by the computer. So when you see carefully, this is the area where you have a motion artifact which appears a little blurred. The same motion artifact you can see in form of doubling of the vessel, or you can see a stretch artifact. After going through all this, I'll invite Dr. Jatinder, who is associate professor as well as a senior consultant working in Arvind Eye Hospital, Madurai. His talk will be on OCT finding in IMT and diabetic retinopathy.
Good morning, everyone. Thank you, Praveen, for making me a part of this instruction course. So whenever we encounter a new technology, there are a couple of questions that come to our mind. Dr. Jatinder. Last. So there are a couple of questions that come to our mind. What is this technology? How does it work? How good is it compared to our conventional tools that we have? When do we use it? What are the limitations of this technology? And is it cost effective to get this into our clinic and our practice? And most importantly, does it change our diagnostic or therapeutic decisions? So we look into some of them. And thanks for the good introduction. I may have to skip a few slides here. So basically, OCT angiography is a non-invasive imaging technique which allows visualization of the retinal macrocirculation without the use of fluorescein dye. So here we see the histopathological schematic where we see the superficial plexus, the deep plexus, the choriocapillaries, and the increasingly recognized intermediate plexus. Similarly, when we get an OCT angiogram, here is a superficial plexus and the deep plexus. They have very distinct pattern. In the superficial plexus, you see more widely spaced capillaries as compared to the deep plexus. And noteworthy, in the deep plexus, we see the ampullae-like appearance that they call as the vortices. So these are around 8 to 12, arranged all around the foveal avascular zone. And the foveal avascular zone in the deep plexus is slightly larger than as compared to what is seen in the superficial capillary plexus. So coming to the most important aspect that we can detect when we do an imaging of vasculature is to detect capillary non-perfusion. So visualization of CNP areas in macular region may be useful indicator of disease severity, though the talk is more about wide field imaging, but even capillary non-perfusion at the macular area can be a useful tool to detect the progression of the disease. So when we compare with fluorescein angiogram, the OCT angiogram edges of CNP areas are better delineated because the leakage of dye that impairs the view on fluorescein angiogram is not there in OCT angiogram resolution. So here is a comparison of normal superficial plexus and deep plexus as compared to that in a diabetic patient with non-proliferative diabetic retinopathy. So you see in the superficial plexus, the CNP areas are better delineated, and the capillary the avascular zone, the foveal avascular zone is more distinctly seen. It has got a more sharply defined borders as compared to the deep plexus. So not much of CNP areas as compared to the superficial capillary plexus are seen in the deep capillary plexus. However, the vortices that we see are completely deranged in the deep capillary plexus in diabetic eyes. So foveal avascular zone in superficial capillary plexus is very similar to what is seen in fluorescein angiogram. However, in the deep capillary plexus, it is larger, and this may be modulated because of the floor void spaces, segmentation errors, or projection artifacts. So foveal avascular zone enlargement is a good marker of diabetic retinopathy progression, and it is progressively seen to be enlarging from a normal to no diabetic retinopathy and larger in proliferative diabetic retinopathy as compared to non-proliferative diabetic retinopathy. So area of foveal avascular zone also correlates inversely with the foveal thickness and volume. So OCT angiogram may not only enable us to assess the foveal avascular zone very well, but also in a diabetic patient with diabetic retinopathy, but also it picks up subclinical changes in patients which are not yet developed clinically over diabetic retinopathy. So this is a patient with no diabetic retinopathy. You can see some dropout areas in and around the foveal avascular zone, and also a little distant away from the foveal avascular zone. So this we can understand the emphasis and the importance of this fact that a patient with no diabetic retinopathy can actually be assessed and picked up so that we can follow these patients more carefully. So coming to microaneurysm, which is an early sign of progression of retinal vascular diseases, it's more prominent. Most 80% of the microaneurysms are seen in the deep capillary plexus on OCT angiogram. And this correlates well with the histopathological studies that were published 2 to 3 decades ago, where most of the aneurysms were seen in the inner nuclear layer on either edges. So this is a comparison, 2 cases, case 1 and 2, showing you the fluorescein angiogram, the superficial and deep plexus, and you can clearly see the amount of microaneurysms that are seen on fluorescein angiogram it's much less on the deep plexus and even lesser on the superficial plexus. Almost 40%, only 40% of the angiogram of the microaneurysms are picked up on OCT angiogram. So the detection of microaneurysms by OCT angiogram is significantly lower as compared to fluorescein angiogram. This may be because of certain factors. Because it deals with the flow, the resolution of OCT angiogram depends on the flow of the erythrocytes. A very slow or turbulent flow within the microaneurysms may be the reason why it is not picked up. And sometimes these microaneurysms may have only plasma and no cells, and that may be the reason why they are not picked up. In addition, all hyperfluorescent dots that are seen on fluorescein angiogram may not be microaneurysms, and they may be just tufts of impaired capillaries with leaking dyes. So here is an example, look at the red arrow. It looks like a large microaneurysm on fluorescein angiogram, but on OCT angiogram, this area is quite hyperreflective. And on the corresponding B scan, this signal is coming from anterior to the ILM. So this suggests that this is not a microaneurysm and it's a new vessel. So anything which gives a flow signal above the ILM is probably a new vessel. So new vascularization is seen as flow signal above the level of ILM, and for that we need to have a good segmentation slab. This segmentation slab is encompassing the entire retina, and hence you're not able to see distinctly the new vascularization. But if you take a slab limited from the anterior surface of the ILM to the mid-vitreous or significantly into the vitreous cavity, you can pick up this new vascular front very well. So selection of a proper segmentation slab is critical when you want to image the area of interest. So this the detection of new vascularization also can be assessed periodically over a period of time as we institute our therapy, either with anti-VEGF or PRP. Different patterns of regression can be noted. And here you can see at baseline, at 2 weeks following intravitreal injection, the new vessels have seen to be significantly regressed, but they recur back at 8 weeks. So this suggests that this may be just a reduction of flow in the blood vessels and not actual true regression of the new vessels that are seen. So this is an example of chronic DME, which is also seen as hyporeflective spots on the superficial and deep plexus. This hyporeflective should not be confused as avascularity or capillary dropout. And this patient has chronic DME and maybe for that reason poor fixation, and that is the reason why there are a lot of motion artifacts also. So there are studies to say that these areas of the CME develops within the areas of the non-perfusion, and after the CME resolves with the proper institution of therapy, there is really no regaining back of the perfusion or the capillaries in that region. So there may be other vascular changes which are increasingly be recognized in the choroid, especially a term called diabetic choroidopathy has been labeled, and this has been published in Retina 2017, where you can see some flow void signals in the choroid capillaries and maybe early sign of diabetic choroidopathy. So we can understand, we've seen well what how OCT scores over the fluorescein angiogram, and better resolution. However, there are some pitfalls that we'll discuss at the end. So coming to MACTEL type 2, there are 2 stages, non-proliferative and proliferative. OCT angiogram better delineates the vasculature as compared to fluorescein angiogram and ICG. In early changes, the leakage that is seen in the MACTEL is because of leakage from the perifoveal microvasculature in the middle layer and not in the superficial or deep plexus. And there is earlier and greater involvement of the deep plexus. So there is a grading here that predominantly class 0 is where there is no visible changes as compared to the surrounding microvasculature. And in class 1 there is predominantly a temporal effect. Class 2 there is medial nasal effect also. And class 3 you can have all around the foveal avascular zone, the changes may be seen. So there is a reduction in the capillary density, dilated dendritic vessels and anastomotic new vessels that are seen in MACTEL non-proliferative stage. So this is an example which clearly shows how deep plexus depicts the changes of the capillaries in MACTEL better than the superficial plexus, and nothing much happening in the outer retina and the choriocapillary slab. This is another case where you can see some hyporeflective patches on the emphase choriocapillary slab, and this is because of the projection artifacts of the pigment plaques that are seen. In proliferative stage, however, you can see the neovascular complex very well, and the communication between the subretinal neovascular membrane and the choriocapillaries is increasingly being recognized, which shows regression following anti-VEGF therapy, along with decreased caliber in the retinal vessels and their anastomosis. So this is an example of proliferative MACTEL 2, where in the outer retina slab you can see this is usually an avascular region, and any hyperreflective in this area should be seen as suspicious. So this is the neovascular membrane that was seen associated with the MACTEL, and following treatment with anti-VEGF therapy, it has regressed significantly, though it has not disappeared. So in addition to the diabetic retinopathy and MACTEL in diabetic patients, because of the systemic risk factors that they have, there are other entities, and the importance of the middle capillary plexus has been recognized. This is in the case of paracentral acute middle maculopathy, which shows significant changes in the deeper plexus. So this segmentation is all automated, but if you do a segmentation of the middle plexus, this will be probably even better seen. So reducing the segmentation slab not only improves the detection of the lesion, but also reduces the noise that is associated with the resolution of the image. This is another example, a patient with moderate diabetic retinopathy presented with serous detachment. And this could have been treated as a diabetic macular edema. But when we saw this scan with fluid, we also saw some RPE changes, and we did a OCT angiogram. So any hyperreflectivity below the flat irregular PED that we see in the macular region should elicit the doubt of a neovascular membrane associated with the CACR. And this is an entity which is called as diffuse RP epitheliopathy, commonly associated with diabetes. And here you can see again the neovascular complex in the blue code image in the composite. So to summarize, OCT angiography is a rapid, non-invasive tool to image the retinal microcirculation. It gives exquisite detailing of the capillary network, enables imaging of the deep capillary plexus, which is not possible with the fluorescein angiogram. It also allows volumetric scans with accurate localization and size information, and thus provides structural and blood flow characteristics in tandem. However, there are some drawbacks and pitfalls of this new tool. There is no equivalence of leakage and staining, a very limited field of view and artifacts, which seem to be getting better with time, and in future probably with new sophistication and adaptive optics OCT, most of these problems are going to be resolved. However, there is a learning curve for this interpretation of these images, and each better understanding of this tool will help in diagnosing a lot of other diseases and expanding spectrum of indications. Thank you so much.
Dr. Jatinder, I have a couple of questions.
Yeah, sure.
So in diabetic macular edema, ischemia and presence of CNPs also will appear as hypo, whereas edema also would appear as hypo. So in the presence of both, or in the just edema, how do we say that ischemic component is also present? Is there something to make out?
Yeah. So first thing is the general appearance of the UNFAS image. Like in fluorescein angiography, also we have block fluorescence and capillary dropouts. But if you see carefully, the capillary dropout areas are seen with a kind of a ground glass haze, whereas block will be absolutely jet black. So similarly on OCT angiogram also, fluid spaces will be seen as jet black, totally black, whereas the non-perfusion area or capillary dropout will have some amount of haze around it. But it's always better to correlate with the corresponding B scan and have a point-to-point correlation and see whether that area is having fluid or there is no fluid. If there is no fluid, we presume that it is a dropout and not a fluid.
So that is in purely ischemic cases or purely edematous cases. But if there is a combination, then it would become more difficult.
Yeah, that's a limitation of this tool. It will be difficult. But when we treat this is what is intriguing, that when we treat these kind of cases, especially the chronic ones, there is no regaining back of capillaries in that area. So it suggests that there is some kind of permanent loss in that area, and the edema selectively develops in the area which is already non-perfused.
Also, in the presence of neovascularization, be it CNVM or NVEs, clinically, right now we have certain endpoints. So we stop treating at that point for a CNVM or in MACTIL associated with the neovascularization. We stop treating at that point. But in OCTA, we see that even at that point, there is some amount of neovascularization seen on the OCT. So do you think that this will redefine the treatment, or
I think fluid
at the subclinical level when we see?
Yeah, I think fluid is going to remain as a good endpoint for a long time. It's not going to go away, that fluid on OCT. OCT angiography, as of today, I believe that it will help you pick up those cases which are going to show early recurrence, or pick up the early recurrences, or have a close watch on these kind of patients, and not just jump into treatment just based on OCT angiogram imaging. So that's my take on it. I think we'll have opinions from the other people also.
That's right. I think there's now an entity in AMD which is also called non-exudative neovascular PEDs, yes, where there is a neovascularization or a fibrovascularization seen under the PED, whereas fluid is not there. So the general take
Yeah,
is that
so-
we don't treat those patients.
Watch them carefully and not treat them.
Exactly. So
watch them
those
till
patients
the-
are high-risk patients which may need a closer follow-up. We may
follow-up.
just think that that is a
Exactly.
drusen, but under it, whenever there's a neovascularization, they would need closer follow-up because they are likely to change to wet AMD faster. So maybe these patients also would require a closer follow-up.
Closer follow. Yes, true. Agree with that.
Thank you. That was
Thank
an
you.
excellent presentation. I invite Dr. Praveen to talk on the OCTA interpretation of vein occlusion and other pathologies.
I'll be projecting a few slides on the angiographic, OCT angiographic pictures, and we'll be having a discussion from the panel, as well as we have for a keynote address Dr. Jeremy Chung from SNEC, who is an associate professor there. So coming to the vein occlusion, the OCTA findings were consistent with clinical, anatomical, as well as the FFA finding. But in conjugation with SD OCT, it could be at least equivalent effective as a FA for evaluation and management of macular complication, especially in patient with vein occlusion. So this was a patient of inferior vein occlusion of 1.5 month duration. Patient presented with a vision of 612. I'm not projecting both the fundus picture as well as the angiographic picture and the OCT picture. We just want to see what information we can infer from the OCTA images. So this is a slab from the superficial segment, and this is from a little deeper segment, and this is from the choriocapillary segment. What we see is a good area of non-perfusion, and we all agree that it is better seen, the non-perfused area are better seen on a OCTA compared to a FA. Now what added information extra you get from these images? I'll ask the panel, Dr. Jatinder. Means by seeing this, can we treat the patient? Vision is 612. We don't see the edema, means we don't have a OCT at present, the SD OCT images, just by seeing these images.
No, that's too much to ask actually. This tool is, I think, we're still in the evolving phase and we're learning more about it. So I don't think just based on OCT angiogram I would base any of the treatments. But what I can see is a good amount of dropout areas, and one edge of the foveal avascular zone is disturbed. But without any information on the fluid, I would not be jumping to any conclusion or counsel the patient for treatment or observation either ways.
Okay, so at present, one of the major disadvantage of OCT angiogram is we can't see the leaks either from the vessels or from aneurysm or NV. One of the major disadvantages. What we can see is basically a non-perfused area. One thing good what I told before is the artifacts. Artifacts should be made out. So if you see the second image, this bright image is basically an artifact from the superficial layer. And in the choroidal layer also, if you see this bright image, it should not be confused with a CNV membrane. These are basically a bright spot from the vasculature above. These are just projection defect.
So Praveen, that disadvantage that you mentioned, that we can't see the leakage and staining on OCT angiograph beam is also an advantage. Because we don't see the leakage of dye, the capillaries are better delineated and you see more sharply defined capillary network on OCT angiogram. So in addition, with the newer advances, they are going to pick up more slower and slower flow. So in the coming years, I think we'll have OCT angiograms which can choose to pick up slow flow, very slow flow selectively, so that we can detect even leakage. Leakage is nothing but very slow flow. So maybe that also can be picked up. So in coming years, we may see some revolutionary like images in the publications.
Okay. This is a second picture. Patient with superiotemporal branch vein occlusion. If you see, there are a lot of CNP area in the superiotemporal part, deeper segmentation. What we see basically is again the same non-perfused area. But if you see the FA, the temporal part, you have a large leak, NV, which is basically difficult at present to peak. The main hypotheses are given as Dr. Jatinder told. It may be due to a slow flow or maybe due to a turbulent flow. Or otherwise the segmentation was not proper. We are just maybe a little below, a little above. Or fourth, last reason given is the OCT angiograph at present, what phase we take is not correlating what the neovascularization has. So at present, if there is coming back, like if we have additional tool like a conventional OCT, basically in case of edema, we require a conventional OCT to go ahead with treatment. And to differentiate in case of new vessels, we have to go with angiogram. Maybe with future advances and future software or application, we may be able to locate the leaks, which is the basis for or a gold standard for treatment for whether it's a macular edema or a new vessel. Coming to the second pathology, which I'll be saying, it's a red-free image, very classic artery occlusion. It's a very acute onset. That's why we can see a gross non-perfused area on a OCT angiogram images also. The third thing which I'll be discussing is about CSE. CSE on angiogram, we may see the pinpoint leaks in acute stage, but OCT, whether we take the superficial or deep or capillary layer, we don't see anything. So is there any take for a CSE? Doctor, anyone from the panel?
CSE, I think, would not be treatable with an OCTA because we cannot identify the leak. Maybe we can identify the, if you look at the choroidal capillary plexus, there may be some amount of hyperperfusion which is there. That may give us an idea, but for the pinpoint leak as such, I think it would be difficult.
The leak, as I told, it's not basically seen. But there was a large study in JAMA 2015 where it was told that the best thing in CSE is membrane. In case of membranes, if you have a membrane, it is more specific and sensitive in OCTA compared to FA. So if you suspect CNV in case of CSR, it is a good way to go ahead with the OCT angiograph where the sensitivity is much more.
So if you see on B-scan OCT, a flat irregular PED with sub-RB hyperreflectivity. So that is an ominous sign and it should be taken as a CNVM otherwise. But in such cases, it has been shown that almost 30 to 35% of these cases harbor CNVM in this area. So whenever you detect a CNVM, you are going to treat it with anti-VEGF and only if there is associated fluid. Just because there is a membrane, you will not treat that flat irregular PED. So this is increasingly been recognized earlier in chronic CSR cases and now even in acute CSR cases. Especially when symptomatically the patient complains of metamorphopsia, you have to be on high alert and have a high index of suspicion that this lesion may be there. Maybe subjecting them to OCT angiogram is a better option as compared to fluorescein angiogram because under fluorescein angiogram, everything is going to become hyperfluorescent. So PED, leakage, even CNVM, everything will hyperfluoresce. So on OCT angiogram, it will clearly show in which slab this hyperreflectivity is seen and then treat these patients accordingly.
In ICG, we see a vascular congestion in the CSC. Whether this can be picked up, the vascular caliber can be picked up at that particular location.
I didn't get you.
In ICG, if you do in CSC, something can be picked up in the ICG. Same thing we seen in the vascular caliber at this localized area.
At present, in the choriocapillaries, I don't think so. We can see the calibers. At present, what we are seeing is basically a very diffuse.
Right now, the resolution is limited to around 20 microns. So we don't have that resolution, and I don't think there are any publications to suggest choriocapillary changes in that choriocapillary slab on OCT angiogram.
So with the SD OCT angiography as such, that is very difficult. But there are publications with the SS OCT technology, and they have studied CSR patients, and they show that the difference in the architecture of the choroidal layers can be made out with the SS OCT, which is not commercially available at present for us. So maybe with the next technology, it will be seen in a better way.
Coming to AMD, as we know that it has been classified basically into type 1, type 2 and type 3. Type 2, the classic CNVM shows a very well demarcated lacy area on a FA. And on SDOCT, what we see is a hyperreflective subretinal lesion and separated from the RP. What we see in OCTA, we see a high flow structure, not only in the outer retina but also in the choriocapillary. There are two patterns which are basically described by L. Amin et al. In Retina 2015, basically into two types, the medusa shape or the glomerulus. The medusa is basically a compact zone of new blood vessel with minimal hypodense structure inside it. So this is how a medusa shape look. It's very compact. You don't see much of hypo structure except for one of few. Whereas in the glomerulus, which is very typical of the kidney thing, where you see entwined vessels and lot of hypodense space in between. If you see the outer area also, which is shown by the white arrow, you see a hypodense area around it. Now coming to the clinical practice, what you see is a very classic CNVM, and you see a glomerular-shaped structure with a hypodense structure around it. So as I told before also, at present the leaking pattern is not seen. So what we see is just a membrane. This membrane does not necessarily to treat or not to treat. Treatment is always based, at present what we have the gold standard is based on the leaking pattern. A nice study was there in retina by Nora et al. She delineated the measurement of the membrane and seen what is the effect post-injection. If you see just 1 week post-injection, the greater linear diameter has reduced drastically. Similar thing was shown by David et al. The picture was taken at 1 day, 1 week, and again at 6 weeks. At 1 day and 1 week, you see a drastic reduction both in the large caliber as well as the small caliber vessel. But on the 4th week and 6th week, you see those vessels perfusing again. So looking at this, how you go ahead with the treatment? Any say for the treatment part of it?
So this patient is being treated with anti-VEGF.
Anti-VEGF. These are treatment-naive patient, just followed up at 1 day, 1 week, and then at 4 to 6 weeks.
Okay. So at 4 to 6 weeks, you see significantly enlarged neovascular complex as compared to the 1 week. So this patient, if the patient is on anti-VEGF, on Avastin, or Eccentrix or any other treatment, I think we have to watch carefully and look for the appearance of fluid or hemorrhage on fundus picture and OCT. And if not, then if there are no such signs of activity, then watch the patient carefully at maybe another 2 weeks. So just based on an OCT angiogram, I would probably not base retreatment.
This is the first injection?
Yeah, first injection. The best part of this is...
So you need to continue the protocol. 3 injections.
Right.
OCT angiogram at the end of 3 injections.
Yeah. So this is just to show how they respond to treatment-naive patients. So the improvement is really drastic on OCT angiograph. Once we follow this patient with second and third injection, what we see in later stages are the small caliber vessels are not seen. What remains is a large caliber vessel. Whether they leak or don't leak is at present not detected on an angiogram. So this is just a fundus picture where you see a large geographic atrophy. An OCT angiogram of that picture show a small membrane just nasal to the lesion. So these are just the structural flow, how they show the inner flow as purple, the outer as yellow, and red as choroid. And what you see beautifully is a small membrane, which is seen in case of just a dry AMD. So these are labeled as non-exudative AMD, and they are seen as 10% will have membrane in these cases. The significance at present is not known. It was followed up for a long period of time, and it is seen on both OCT and FA, but this membrane don't require any treatment. Sark et al. Has shown histology of other eye which showed membrane up to 17% of the cases. At this time, it is really uncertain whether one is a predecessor of the other or whether they are two separate entities. It is hypothesized that the non-exudative CNV may be a mature form of CNV that has developed a competent vessel. Conversely, GAS has told that this network may initially be a low flow with minimal or no exudation. As they develop, the flow may increase and exudation may increase. Currently, there is no recommended treatment for asymptomatic non-exudative CNV, but may be followed up really closely with warning symptom explained to patient. Bit about PCV, we know that they are major cause of blindness after 50. ICG is characterized by a polypoidal dilatation as well as BVNs, and OCT is characterized by either a dome-shaped elevation, and BVN is seen as a double layer sign. On OCTA, what we see? We see the BVNs as a hyperflow structure, and the polypoidal lesion we see as a hyperflow round structure surrounded by a hypointense halo. So this is just a case of PCV. What we show with a gray arrow is the branching vascular network. This is the polyp, which is seen as a hyperflow in between with a hypo around it. Another case where I we can see this polyp as a hyperflow and a hypo around it. Just few limitation also before summing up. At present, there is no supportive clinical data to demonstrate the utility. The cross-validation between technology is required. Interpretation depends on how you segment, and loss of sensitivity decreases with the depth. Currently, the cost at present is unclear of different technology. And last but least is the artifact, which is an interesting part of this technology. Now I invite Dr. Jayashree to speak on SwepSource OCT.
Dr. Jayashree is a consultant at Eye Foundation, Coimbatore, and she will give us her talk on SwepSource OCT.
So we move on to the next technology which is available with us. That is the SwepSource OCT. So looking at what exactly a SwepSource OCT it is also a Fourier domain OCT similar to spectral domain. But when we say SwepSource, it just refers to the type of laser which is incorporated into the device. Instead of the superluminescent diode laser, which is typical of a conventional spectral domain OCT, here this SSOCT technology uses a short cavity swept laser. So it's a rapidly tunable laser which changes its wavelength within a narrow band. So grossly, the wavelength which is used is 1050 nanometers, but it actually changes with each scan, and varying depths can be scanned with greater sensitivity because of this tunable laser. And it's faster than all existing SD-OCT instruments. So basically, the important differences would be the source with the diode, which is replaced by the tunable laser, and the detector, in which a photodiode detector in the SSOCT replaces the spectrometer and the charge-coupled device camera, which is used in SD-OCT. The limitation of this charge-coupled device camera is that it has a finite pixel size. So as you go deeper, there is a drop-off in the signal which occurs here, whereas in the photodiode detector, it is not so, and hence it has a greater sensitivity. That, coupled with the invisible light source and the sophisticated automated segmentation software, gives us a greater advantage in this technology. Basically, the EDI OCT can also be used to image deeper areas, but then we do not have an automated software in that. We have to measure it manually. We have to manually segment it and manually measure the thickness with calipers. That becomes difficult, whereas this software is highly advanced and would give us an automatic choroidal thickness map. So the most important attributes with this technology would be the high imaging speed, the less sensitivity roll-off with depth, and the deeper range of imaging. Looking at the advantages of each of this, the speed is anywhere between 1 lakh to 4 lakh A scans per second, which as compared to the SD-OCT technology that we currently use is only 50,000 A scans per second. So with this improved speed, the fixation and motion artifacts would not be there, is what we assume, but even if it is there, it would be less of an issue. And larger areas can be scanned quickly, resulting in extensive averaging and better quality of the images. And this will be very patient-friendly, especially for elderly patients, young children, and patients with advanced AMD in whom fixation is a real problem. Looking at the sensitivity, when we first started using time domain OCT, it was thought that imaging beyond the RP is not possible, and this is mainly because of the light scattering effect by the RP. With the EDI OCT, it became better where we shifted the zero delay line a little behind. And now with this technology, the light scattering is very less, both by the RP as well as by the lens opacities, and hence clearer images can be obtained in patients with cataracts. Apart from this, there's a uniform sensitivity over the entire scan area. So in a single scan, we can see the vitreous, their retinal layers, as well as the choroid with equal clarity. So we see a scan here comparing the SDOCT and the Topcon SSOCT, where although the SDOCT is also clear, but you see the increase in the clarity of the images using the SSOCT. When we talk about the depth of imaging, it's a longer wavelength, it's 1050 nanometers, so definitely the penetration is going to be greater. There was a comparative study which was done at the Doheny Eye Institute comparing the choroidal visibility between two OCT machines, one using the 840 nanometers and the other 1050 nanometers, both with the spectral domain technology, and even in that they found that a longer wavelength has a better visibility. So that coupled with the newer technology would give us greater clarity in choroidal imaging in the SWEPSOS OCT. And along with that, we get this kind of a choroidal thickness map also. The other advantages would be the greater field. We get 12 mm B scans, which are possible, and a single scan can show the disc as well as the fovea. So overall, with the SSOCT, we get better images. That is mainly because of the better penetration, because of the longer wavelength, the better resolution. Getting 12 mm B scans is possible, faster scanning, and minimum eye movements due to the infrared light source. So here we see a scan in which we can see the vitreous with a greater clarity, the retinal layers, and the depth of imaging is really good. Imaging the vitreous has never been better before. So now that intravitreal pharmacotherapy is the first line of treatment in many medical retinal conditions, imaging the vitreous would be significantly, very significant. So we have seen patients, some anti-VEGF injection or a particular pharmacotherapy which has worked well in one patient may not work equally well in the other patient. And so far we have considered retinal perfusion, load of anti-VEGF, load of other inflammatory factors and to be the key factors which are responsible for this variation in response. But now with this imaging of the vitreous and the vitreous dynamics becoming possible, it is thought that the vitreous structure and the dynamics also may play an important role in response to the intravitreal therapy, and hence this may provide us with good insights into why a particular patient is not responding or why a patient is responding well. Imaging the choroid would also be of greater would also become very clear with this. So a major advantage here would be the presence of blood either in the subretinal space or in the sub-RPE space would not hinder imaging, although the images would not be as clear, but still some amount of choroid will be visible under this, and with improvement in technology, maybe these images will become clearer. And as I said, the identification of the architecture of the choroid is also better in this. So even in the presence of CNVM, with the EDI now, we have studies which say that the choroid is thicker in some patients. Some studies say that there's no difference in the thickness of the choroid between normal patients and between CNVM. Some say that it is thinner. But the actual difference would be in the architecture of the choriocapillaries, the hollows, the satellus layers, and that would become evident with this. Imaging of choroidal nevus, the exact extent size would also be possible. And in the study of CSR, it is seen that the documentation of the RP and choroidal vasculature may help in elucidating the pathophysiology of the disease and can potentially contribute to the diagnosis and the management, especially in chronic conditions. Another important application would be high myopia, where the posterior staphyloma and the longer axial length makes it difficult to get sensitive images with the current technology. So here we have an image of myopic retinoschisis in a patient with staphyloma, which is very clear. And when we compare the SSOCT images, on the left side are the SSOCT images and the right side the SDOCT images, the clarity and resolution, the longer scan, that is the width of the scan, and the depth of the scan also gives us an idea that myopia may not be a challenge with this technology. Also in optic nerve head pits, we may be able to see the actual communication of the pit, the depth of the pit, and may also help us in seeing whether after the newer surgical techniques that we use where we plug the optic nerve head pit, whether it actually works or not post-surgery, may be seen with these scans. Imaging the choroidal tumors may be an exciting new application, and the study of the vitreous dynamics and possibility of quantification of vitreous cells will also provide new insights into the vitreous. Newer applications in the anterior segment imaging like late onset capsular block syndrome, imaging the iris, measuring the peripheral anterior synechiae, as well as ONH imaging may give us improved visualization of the deep ocular structures in glaucoma. And there are also trials to study the total retinal blood flow using the SWEPSOS technology. So in a little more than 2 decades, OCT technology has progressed to a point at which we can visualize retinal and choroidal anatomy with a precision, and SSOCT adds a new dimension to this. For the first time, we can in vivo visualize not only the vitreoretinal interface, but also the cortical vitreous. And SSOCT will likely further expand the applications and the importance of OCT in our practice. Thank you. Right now, they say that the suprachoroidal lamella are seen, but this is all at the research level, and we've not had any practical experience with these instruments as such.
So thank you, Dr. Jayashree, for your talk. As Dr. Hari gets ready for his presentation, I have a question. What's the transverse resolution difference between the SD OCT and the SWEPSOS OCT on angiogram, OCT angiogram?
The transverse resolution is 1 micron, but the depth is considered to be better.
Yeah. So actually you get better resolution,
yes,
but transversely I believe there is not much difference.
Axially they say it is about 2 microns.
So I think adaptive optics OCT will add, and Dr. Hari will be speaking on that right now. Dr. Hari, to you.
Good morning. I thank Dr. Praveen and the AIOS to invite me to talk on adaptive optics and OCT. I mean, the topic was essentially wide field OCT, but adaptive optics is essentially to see more retina in less retina. Here, normally in a fundus photograph, you see a large area, and the OCT will take a scan right from the across the macula there. But when we talk about adaptive optics, what we are trying to see is at a more microscopic level, at a photoreceptor level, how beautiful the images see, what is happening at that level. So that is all is adaptive optics about. So you can get very beautiful images. These white dots that you see here are the cones. So to that level, the resolution can be done. So what exactly is this adaptive optics? And how is it useful as a tool to help us improve the scanning in OCT or understanding the images of the retina? Adaptive optics is a technology used to improve the performance of any optical system by reducing the optical aberrations. See, the human eye has certain aberrations. The concept of adaptive optics was actually started in the astronomical field so that the atmosphere doesn't remain a hindrance for space viewing. But then the same thing was adapted to the eyes, not only in the anterior segment, but even for better imaging of the retina. This helps us to give better quality scans and to detect and monitor pathological variants in preclinical stages. Because we find diseases at a much later stage, so whether we can pick up things at a much subtler level, at a more microscopic level. So what are these optical aberrations? Most of them, almost 90%, are the lower order aberrations like astigmatism, whereas about 10% of them there's a contribution towards higher order aberrations also. So almost 25 years back, in 89, first it was described, in 97, a seminal paper by Dr. Liang et al. Had talked about adaptive optics. But then nothing really developed over a period of time, essentially because the other OCTs really came up big, whether it is the Stratus or the time domain or the Fourier domain OCTs. So, but adaptive optics has been used for flood illumination, fundus imaging, confocal SLO, and for OCT. These are the kind of, these are all prototypes. None of them are available commercially. There are some of the centers which have it all over the world. So what you get is, you are able to get images. This is the fundus image that you see on the OCT image, the red-free images. But you see this microscope, you can analyze this small area, which gives us about 500 cones. You can actually count. You will be able to get a picture of this. You can see the FAZ is really magnified. At the nerve fiber layer, again, you can able to identify the bundles of the nerve fibers, how thick they are, how thin they are. So the level of analysis really goes deep at a microscopic level. So the basic principle is, there are light sources. You need a system to sense the waves, all the aberrations. So you need something to, you need a wavefront sensor which will detect all the aberrations. You need a corrector which will help to correct these aberrations, and a system to control them. So three things that are required: a sensor. The most commonly used wavefront sensor is the Hartmann-Shack sensor, but other than that, there are some curvature sensing, pyramid sensing, and interferometry that have been used. A corrective element is the most difficult part of it, the deformable mirror, the most expensive part also, and you need a control system. This gives a better idea about how a Shack-Hartmann wavefront sensor works, and this is how a deformable mirror works. So the eye gives out images which has a lot of aberrations, and with the help of a deformable mirror, we are able to correct it. And then the detector, the machine detects those waves, all the images without the aberrations that are present. So this helps to increase the lateral resolution up to 2 microns. It reduces the speckle size and increases the sensitivity to weak signals. So an OCT image like this, you are able to analyze a projection view, NFAS imaging, where separate photoreceptors are actually visible. And you get this kind of confocal AO SLO images also. Earlier, we have started imaging the photoreceptors, the cones more often, but now even the rods are slightly started. We are able to image them in certain individuals. So, not only rods, cones, the RBCs at a microscope, the RBCs, the RPE, the lamina cribrosa, all of them can be seen. You require 2 light sources separately. One of them is to measure and correct the aberrations itself, and the other one is used actually for imaging purposes. So you do get images of the nerve fiber layer. So what is important here becomes is the region of interest. See, if you take an image which looks normal, if you see at a lower level how it looks, so this is magnified, and then you try to see what is happening at that level. So what is important is to know the region of interest. We are able to identify the cone packing density up to 40,000. Different studies have quoted different figures. What is the cone spacing, and how regular are these photoreceptors? The hexagonality of them can be measured. So when you talk about region of interest, if you look at a patient of dry AMD, these photos kind of show which area of geographic atrophy we are talking. But here, an OCT image which takes a line scan here, and in a small area, if you take a adaptive OCT picture, you will be able to identify the cones are preserved at the border of the geographic atrophy, whereas actually in the area of geographic atrophy, there are no cones present. Again, in a patient, here, this is a normal fundus OCT, and this is the OCT picture of a diabetic patient with no diabetic retinopathy, absolutely no diabetic retinopathy. But then, if you see the photoreceptors in a normal patient, they are more densely accumulated, whereas here they are more distributed. So these are something that have been observed. We have not interpreted why this is happening, because diabetic retinopathy is more of a vascular problem. Now we are talking about a photoreceptor problem in diabetic retinopathies. So these are images that are coming, and people are trying to interpret how to go about it, these things. Here again you see there's a small area of focal leaks in a diabetic retinopathy. But again, if you take a scan right next to the fovea, that is corresponding to the area of the microaneurysms, we are able to identify that those areas which are slightly edematous, the quality of the image reduces. Because of the edema, the imaging of the photoreceptors also reduces. So those bright images that you saw earlier in a normal fundus, you are not able to see in these patients. again in high myopia, because when we talk about longer axial length, there are studies which have shown that the cone density is actually reduced in these patients. This may be due to the stretching of the retina and the choroid and the sclera in very high myopes. And there have also been studies which have shown that higher order aberrations are also more in these myopes. So currently, what are the uses in these experimental models? One is to study the photoreceptor density and structure in inherited retinal degenerations, assess the photoreceptor function, to decide which patients will benefit from treatment, and monitoring the response to treatment. Again, these are experimental things. I'll give you an example of a patient this paper was published last year, about in choroideremia, how the images are there. See, you will have patches where there's a large patch of choroideremia, but where exactly the problem lies, how exactly this is the OCT image, and then if you see these small areas which are further analyzed on this, these studies clearly supported the data available that RPE is the primary site for degenerations in patients with choroideremia. But they also said that photoreceptors may also degenerate independently to the RPE. We are able to do single cell analysis, and these modalities may be useful in monitoring disease progression. The same choroideremia patients, when you see over time, it's very difficult to analyze in 6 months whether it has progressed or not. But when you see at these microscopic levels, they claim that the more degeneration, the speed of degeneration can be seen. Again, in patients with achromatopsia, where color blindness is there, we can say the percentage of loss of cones can be identified. The residual cone density can be judged. So prognosis for these patients can be said. And response to treatment, if any, when you're talking about gene therapy, how the patients are responding. Over a period of time, these images may help us to know about it. So presently, high-resolution images of photoreceptors at a microscopic level is possible. In certain Stargardt's disease, you're able to know which area is normal, which area cones are doing well. And again, at the edges of a geographic atrophy, the cones, you can identify and know whether they're progressing. The geographic area at a microscopic level, is it progressing or is it static? But, well, there are lots of limitations. It's a new technology. It's very expensive, not commercially available. There is no normative data because everybody builds a prototype with certain parameters. So there's no standardized protocols for different data. Again, because you are viewing extremely small areas, unstable fixation, low visions or media opacities, it is a problem. Lack of reproducibility and comparability of data is at present not there. So as a future, definitely it's a basic science technology. So for visual science, yes, it's a promising new technology. It may provide a sensitive measure of cone function in retinal degenerations and response to therapy as time goes by, and may yield insight into mechanisms of cell death in several types of retinal diseases, especially these inherited diseases for which we have very little to offer. Thank you.
Thank you, Dr. Hari.
I want to ask you this. When you see those RPs, the choriocapillaries, those each, because I see in the figure there's a large vessels are there, whether the small lobulated capillaries can be picked out just behind the RP.
Yes, they can be picked out on these images.
Thank you, Dr. Hari. With over 80 peer-reviewed articles and several clinical trials under her, I hereby call Associate Professor Jamie Chang from Singapore National Eye Center to add her keynote.
Thank you. It is my pleasure to be in Jaipur and to participate in the AIOS. Thank you very much, Dr. Praveen, for your introduction. So I'm very lucky to follow a very good string of speakers who have already laid down some very important basics and fundamentals of OCT angiography, which is a new technology, and we're all learning to use it. So I'm very glad to share with you some of our experiences using this technology, particularly in AMD and PCV in our population. Is a big chunk of the AMD. So these are just my disclosures. So as you all know, there are several commercially available machines, and in my practice I've used some of them, including the AngioView, as you can see here, and all of us have to get used to the preset segmentation and the various manipulations that you can use for each machine to get the most of it. I've also used the Angioplex from the Zeiss, as you can see here, and some of the previous speakers have shown images of that. And particularly for this talk, most of my data was derived using the Triton from Topcon, which used swept source laser source, as already mentioned by Dr. Jayshree earlier on. And one thing I like about this machine is that it's multimodality. This presence of a color photograph is quite convenient because we can correlate what we're seeing. For example, one big question is there blood that's masking the image? And this particular utility is quite useful. But between the various instruments, I think all of us just need to dig in there and use them before we can say whether there's any preference. And to me, I think all of them can produce beautiful images. And there are some differences. For example, the Triton advises us to try to use mainly the outer retinal slab for identifying CNV, whereas in the AngioView and also the Zeiss, they tend to tell us to use the choriocapillaris lab, possibly because the Triton has a deeper penetration. But as you can see here, we've got 4 eyes image on 2 platforms, for example, and both of them show up the lesion beautifully. This is the Zeiss imaging other kind of CNVs using the 6x6 protocol, and you can see they can image very large CNVs as well. So all 3 instruments are there for us to use. Earlier speakers have already laid down the principles of OCT angiography, and by and large they are similar, but each individual machine or instrument has some differences. Of course, the swept source currently offers by far the fastest commercially available and uses a longer wavelength, but then again there are also other advantages. Other platforms also can offer you, for example, differences in eye tracking, in software as well. And ultimately, as simple clinicians, all I want is, I'm not a physicist, I don't understand all this OMAG, SADA, etc. I just want to see a clean, clear, and depth-resolved flow image. And sometimes that depends on what is the pathology. So some instruments I find may be better at looking at the superficial plexi for diabetes, whereas other instruments may be stronger at imaging deeper, such as for CNVs. So for AMD, coming back to our main topic, in other publications it's been suggested that we can see the flow in about 75 to 80% when we compare with FA. And when you can see the network very clearly, it helps, because you may say, if you are time limited, you may say, I will skip FA, and you can be rather confident about that. But in PCV, it is a bit harder. We can see the BVN, the vascular network, but seeing the polyp is a little bit more difficult. And we've recently published our data examining about 86 eyes with CNV and PCV. Just going to share some images with you. So our experience with CNV is similar to what's been published and mentioned by earlier speakers. You can generally see the network very nicely. You don't see the leakage, which is in a way an advantage, but then again, you can't, when you see the flow there, you don't know if it is actually causing fluid leakage or not. But with treatment, this is a treatment-naive case, but with treatment, the pattern does change. It tends to arterialize. The main arteriole becomes chunkier and thicker, whereas the fine vessels become less. And here, just to show you 2 kind of software that may also help us. One is a composite, where you can see the light blue outlining particularly the CNV in the outer retina, and here the density map, again, quite useful for follow-up to see how the size of the CNV changing. So this is similar to what has been published. We can see the network in about 80% of cases. This is a case that has been already mentioned. Now, when we see the CNV on FA, I think the OCTA shows us like nice pictures to compare with, but this is really an area where it is very helpful, because even sometimes we don't do the FA, and even when we do the full house, we do FA, we do ICG here. It is a bit hard to tell whether there's CNV or whether there's a little bit of occult CNV underneath there. But the OCTA shows it very beautifully within seconds, non-invasively. In this case, there is a tiny bit of shallow fluid, there is pachychoroid, and there is definitely some occult CNV there, and we couldn't really make up our mind looking at the conventional angiography. Now, coming back to PCV, sorry. Now we can see the branching vascular network very nicely in both cases compared to the ICG here and over here. Whereas the polyps, they can be seen in about half of the time, 40 to 50% of cases, and even in these 2 cases, you can see there is a a variable appearance. Sometimes they look very bright and they correlate very well to the ICG. Sometimes they can look dark, or sometimes they can have a bright rim with a dark lumen, probably reflecting the differences in the flow rate and the turbulence within the polyp itself. So this is just to summarize again for the branching vascular network, very similar to CNV, 80%, whereas for the polyps itself, only about half of the time you can see it. Some more examples of bright polyps up here, dark polyp, and a bright rim with a dark lumen. In all cases, whereas the branching vascular network can be seen very easily. So, but if we compare with ICGA as a gold standard, if you say, can I screen for PCV using the OCTA, I think the sensitivity is a bit of an issue. So if you can find it, it's great. You can get the diagnosis. If you don't see it, it can be like this. You can't confidently rule out that it's a PCV, so you still need the ICGA. So the other feature I would like to point out, while a lot of the beautiful images are based on the en-face images, the B scan is also very helpful, because here we may think in this notch may be a polyp, and here is not so obvious. But when we look at the B scan cross-sectionally, you can see that the flow signal outlined by the red signal here is quite widely spread across this lesion. So it is actually more like a CNV. The whole lesion has flow, whereas over here, the flow signal is localized in this roundish lesion just beneath the PED. So that is very typical of PCV. So that is another feature in addition to looking at the en-face image that I would recommend to you. Now, another very useful screening tool is to screen out the RAP, which again, or even on ICGA, sometimes gets confused with PCV. So in RAP, similar in a way to the parafoveal telangiectasia, you will appreciate some abnormal vasculature either in the superficial or deep plexus, and when there is subretinal neovascularization, obviously you can see the CNV down there, but it is really the presence of the flow signal within the intraretinal layers that helps us differentiate this lesion. This is for RAP, and this is for, again, another example, we can see the signal above the RPE. Now, this is a very hot topic. How do we use it in terms of monitoring? So I just want to show this another feature which is useful, where you can register the two OCTA between visits, so exactly the same place. And of course, we can see the structural OCT has improved. The flow signal has also decreased as well. But by and large, the two are agreeing with each other, about 90% of cases. And we have beautiful images, but I don't think in this case it tells us something I don't know already from the structural OCT. Except occasionally, when you screen many patients very frequently, you will have this kind of situation. This patient had combination therapy. You can see the flow signal has gone away very nicely, particularly on the density map. With further follow-up, we see that there is no significant reaccumulation of subretinal fluid, but we can appreciate clearly the network is coming back. Now, the question is, do we restart the treatment here without any presence of fluid? I think all of us can profess our own preference and opinion. Ultimately, we really need a clinical trial to show us whether treating at this point or whether waiting till there is clear fluid to treat would give you a difference in the clinical outcome, which is visual acuity. So we don't know yet. Just some more examples showing that while there is dry retina, you can see there is residual flow in 90% of cases. So we really need some more clarity in this area. Now, there's another area that earlier has been a question has been asked. In addition to looking at the CNV network, we definitely, at least with this web source device, we can look at the choriocapillaris. Okay, this is after combination therapy. We appreciate an increase in the area of choroidal non-perfusion, possibly related to PDT. Another one, we can see the complex going away after combination therapy. Now, if I drag the slab down to Haller's layer here, we can appreciate the Pachy vessels that reduces in caliber after combination therapy and slowly comes back as well. So I think these are two new areas that we can look at in addition to looking at traditional areas. Just very quickly mention, earlier speakers have stressed, and I think it's very important to be aware of the various artifacts that can be there signal blocking from various other structures, and ultimately poor segmentation. But just to share with you that all the companies are improving very rapidly, such as with OptoView, you can have artifact removal of this motion artifact. You can see the vessel lining up here. Similar with the TOPCon, it can remove the white lines there with this removal. Projection artifact mentioned by Dr. Praveen. You can see the superficial plexi superimposed onto the deep vasculature, which we know should not be there. This is with the OptoView that they can now remove this projection artifact. We have a clean slab showing what is truly the deep retinal plexus. Similar kind of software with the TOPCon device. This the superficial vessel should not be there, and after we apply the software, it's there. And again, segmentation made easier. You can manually change one segment, and all the companies are trying to auto-propagate. So this is with OptoView. You can see this vessel coming back after you change the segmentation. This is with TOPCon. All these lines are artifacts, and that's after the removal as well. Finally, with faster scans, we are going to have bigger field of view. This is 9x9 beautiful images, and you can make mosaic. This is with TOPCon. This is with OptoView. Zeiss is doing it as well. I think all the platforms are doing it. So it's an exciting time for us. It's just for us to try out all the instruments and make the most of it. And finally, a little advertisement. I'd like to invite all of you to come to Singapore in June. We have a lineup of great panel of speakers, including keynotes from Professor Neil Bressler, Phil Rosenfeld, and Richard Spade. There will be talks on imaging if you're particularly interested in this area. Thank you very much.
Thank you. A very nice presentation. Just the last one question. In non-responders, measuring the GLD, we can make out whether they are non-responders, or do we have to still follow up all these patients at 3 monthly or 6 monthly?
So it's non-responders in what sense?
Non-responders means when we give injection 3 injections or 6 injections, we label them as non-responders.
Right.
In OCT angiography, just measuring the GLD, when we see that they are not resolving, can we label them as a non-responders or?
No, because as mentioned by earlier speakers as well, you're talking about the time scale. If you image them at 1 day, 1 week, possibly there is a reduction in the lesion size. But when you're only re-imaging them at 1 month, it could be what you're seeing is the size is exactly the same, but there has been some response in between that you don't know about.
Thank you very much. I thank all the co-instructors for this wonderful talk on OCT angiography.